Again, my name is Dr. Ahmad Rosli. You can call me Ahmad from Gene Solutions. We are a biotech lab and we specialize in cancer screening. And today, thank you so much on behalf of NSCM as well. I'll be presenting on a couple of topics. And the first one will be, as you can see on the slide here, screening and early detection of cancer at the primary care level. And without further ado, let's begin. Okay, so this slide here shows that, naturally we are afraid of cancer. And it's something that we can't control, or anything that we can't control, we have a natural tendency to fear. So cancer is uniquely frightening. It can happen anytime. And despite advancements in cancer treatment, it still remains the leading cause of death worldwide. And hence awareness is paramount, is key, is important, essential in terms of spreading the importance of in the topic of today, cancer screening for early cancer diagnosis and cancer treatment as well. So cancer. So cancer is different than how our body is supposed to normally function. So at the heart of it, cancer occurs because a single cell in the body one day decides to go haywire. And when the cell goes haywire, it then brings along its friends, and they all become haywire, and they disrupt the normal functionality of our body and our cells in the body. And when they grow, these cancer cells grow, they go through various stages, right? Stages of tumoral or cancer cell growth. So we can see from this diagram here, I'll make it as simple as possible. So usually when cancer starts, patient symptoms would increase over time in terms of the clinical features of one having cancer would be more debilitating over time. And that also would lead to the need, if you look at the bottom part here, for effective cancer screening methods, for effective early detection, and then for effective cancer diagnosis. So across this whole cancer care continuum as well. So we focus at this first part here, or the first two parts here, cancer screening and the importance of cancer screening, as well as early detection. Okay, oops, sorry. Okay, a bit of an overview look on cancer. So we look at the global and the local, burden of cancer. So at the bottom left here, this box here. So more than 14 million people develop cancer every year on a global scale. And this is set to rise to 21 million by 2030. So we're not that far off in terms of how many years left. And sadly, cancer is on the rise, keep on increasing as we speak. And cancer causes almost 1 in 6 deaths globally. And hence, coming back to early diagnosis is paramount and can greatly reduce this burden. And this shows that also most people diagnosed with cancer live in low and middle income countries where 70% of cancer deaths occur. So low and middle income countries. Now looking from a global overview to Southeast Asian outlook, right? So we have about 3,000 new cases of cancer each day in Southeast Asia. And then 70% or more than 70% of cancers in low and middle income Asian countries are diagnosed in the late stage. So cancer, we have the cancer staging, the first slide that I showed. So we have cancer stages from 0 to 4. So cancer stage, as you all would already be aware, you have cancer stage 0 to 3, and then we have our late stage or advanced cancer stage, which is stage 4. Okay. So still looking at cancer stats. So from the International Agency for Research on Cancer on a data published in 2022, one of the latest data on cancer statistics on the Asian and Southeast Asian scale. We can see for Asia, the top 5 most common or frequent cancers are lung, breast, colon, stomach, and liver. And it pretty much applies to all the countries that we see here. But specifically, if you look at Malaysia, we have prostate cancer as well being in the top 5, along with breast, colon, lung, liver as well. And then in Malaysia, we see the population that we have today, the number of new cancer cases that we have for the year of 2022 is more than 50,000 people diagnosed with cancer. And then from this is the mortality rate out of these new cases that we get from cancer in Malaysia. So you can see here, the bottom left here is the top 5 most common cancers in Malaysia. And in Malaysia, in terms of the age-specific incidence for all cancers, as we can see from this graph here, we can see around at the 40 years old age and above is where things increase exponentially. So it also leads to our bodies, and it's the course of nature. As we grow older, the cells in our body, it has a natural tendency to mutate. So mutations occur in all of us. We all have mutations, but whether or not these mutations lead to cancer. So this 40 to 44 age group, or 40 years and above, from this point, the incidence of cancer increases because these mutations in our body, which was a bit more manageable, a bit more controlled before when you were younger, it becomes uncontrolled, and then that leads to the spike in the increase of cancer, as we age from 40 years and above. So by 2040, the incidence of cancer in Malaysia is predicted to double, and approximately 1 in 10 individuals in Malaysia will receive a cancer diagnosis in their lifetime, and the lifetime risk of developing cancer in Malaysia is 1 in every 10 males and 1 in every 9 females. So we're talking about more than 10% on average for men and women in Malaysia. And then this busy slide here, just to show when the most common cancer types in Malaysia are diagnosed in men and women, and when are they diagnosed. So on average, to put simply, all of these cancer types, breast, colon, lung, liver, prostate, the average is around 76% of these cancers are diagnosed at the late stage. And the late stage is, stage 3 or 4, right? So, and we can see, the stats for breast cancer and etc. we see here. So, there's a need to, improve on things related to cancer, and reduce the mortality rate, and the comorbidities that come with it, and so on and so forth. So we can take action, and we should not fear. And then the survival rate, if cancer is detected early, is 4 times higher than if cancer is detected in the late stage, right? And in the case of breast and colorectal cancers, more than 90% survival if cancer is detected early compared to the late stage. And then also, we have around 2 to 4 times less expensive treatment if cancer is detected and diagnosed early. So it has a lot of, socio-economical impact, as well as the mental, emotional burden when one is diagnosed with cancer, and hence the importance to detect and diagnose cancer early as possible to help with these factors. So, reiterating, strengthening early diagnosis improves chances of survival, and continuing for millions of people worldwide living with cancer. Okay. So a bit of recap. I know Dr. Murali talked a bit on the recommended or standard cancer screening methods. So this slide here, just to reiterate on what we have here, the gold standard screening methods that we have for the most common cancer types. To recap, for the breast, we have mammogram. Cervical, we have our HPV testing. For colon, colonoscopy, for example. Lung, we have our low-dose CT scan, and prostate, we have the highly effective and highly accurate PSA-based testing marker. And then, however, 71% of cancer deaths are caused by cancers without recommended screenings, right? So again, leads back to the question where we need to have an effective cancer screening diagnosis, strategy, right? So, enter multi-cancer early detection. So what is multi-cancer early detection? So to put simply, it is the ability of a test to screen for multiple cancers at one time through simple, convenient means and non-invasive means. So for example, through a simple blood draw, right? I'll get to that in a moment. So this graph here, again, to put it simply, as we can see, in terms of detecting cancer, the number of people needed to screen in order to have to detect the prevalence of cancer, it actually increases if we are able to screen for multiple cancers at one time. So here you can see this graph here, for example, esophageal cancer, right? You need to screen 1,000 people to get a prevalence of just over 0%. So you need to screen a lot of people to find out, okay, so this is, the number of people having esophageal cancer. So it's not that feasible, not that economical, not that sustainable. How about we combine multiple cancers and we screen them at one time? When we do that, for example, we combine esophageal, stomach, liver, pancreas, colorectal, other cancers into one simple cancer screening test, you sort of have a universal or multi-cancer early detection test. And with this, you don't need a high number of people to screen in order to detect the prevalence of cancer in the population, right? And hence helping with the early screening and early diagnosis of cancer. So this part here just shows that, reiterating what I mentioned. So esophageal cancer, you need 1,000 people to detect just one person having cancer. This is based on the average statistics in Malaysia, cancer statistics. Liver cancer, this is the number that you would need. Colorectal, this is the number that you would need to get just one person being diagnosed with cancer. And then again, reiterating further is if you have multi-organ or multi-cancer early detection cancer screening, you would need around, if you combine all of these cancer types, you need just 33 people, number needed to screen, and then you would have a higher detection rate, and you would then be able to look at the prevalence or detection better, hence the need for multi-cancer early detection. So how can we do multi-cancer early detection? And where does it fit in the cancer care continuum that I showed in the first slide? So multi-cancer early detection, because I showed a slide on your recommended cancer screening methods. So multi-cancer early detection comes with it. It complements your gold standard of care cancer screening methods. So one would be able to do multiple cancer early detection before you would go for your standard cancer screening methods, right? So it would help with the detection of, so multiple cancer early detection testing, we are primarily looking at circulating tumor DNA, ctDNA to make it short. So this is the current available technology for MZ. So this illustration here, not to worry, I'll put it, explain as simple as possible. So in our body, we have cells in our body that grow and die naturally. Healthy cells, so when these healthy cells, they grow and they die, because in every cell in our body we have DNA, right? So when these cells, they die, they release the DNA into our bloodstream, into our blood. So we have DNA flowing in our blood. But in the event that a person has cancer, in addition to healthy cells, they also have cancer or tumor cells, which also grow and die and release DNA into the blood. Okay, so now we have healthy DNA, we have cancer DNA in the blood. So in layman terms, cancer DNA in the blood, another way to look at it, the another term, related term for it is circulating tumor DNA. So one that has tumor in the body or cancer in the body, the cancer cells grow, they die, they release DNA into the blood. So this DNA is called circulating tumor DNA, okay? So MSAT testing, we are able to detect this cancer DNA in the blood in order to effectively screen for cancer. So it complements your recommended screening methods, for example, your mammograms, colonoscopy, right? So they are more looking at the anatomical level, right? Looking at the anatomical features of your body. But MSAT is able to complement that because it looks at the molecular level. It looks a bit deeper. It looks at the DNA of oneself, right? To see if there's an possible early detection of cancer before it, is able to be detected via your cancer screening methods, your mammograms, CT scans, etc. Which again looks at like heart features, like I mentioned, anatomical features, as opposed to DNA, right? So this is a better illustration of how ctDNA is released into the bloodstream. Okay, I'll display this video again. So if this is a cancer cell or tumor cell, so it naturally releases DNA into our blood. So this is our artery, our vein, and then these are the circulating tumor DNA. And then from MSAT, multiple cancer early detection technology, we're able to detect for the presence of this circulating tumor DNA in the blood. So again, it's different than how your standard cancer screening methods work, but they complement each other. And MSAT testing is the new frontier in early cancer and effective early cancer screening. Okay, so this slide, again, a bit busy slide, but it goes to show, again, emphasizing on the complementarity of cancer screening methods and MSAT technology, which would come, you do it earlier, you do it before your cancer screening methods. Why is this so? We can see the ticked parts here. So for your imaging, for example, your mammograms, colonoscopy, they are primarily used for diagnosis, to aid treatment, and then to detect for late recurrence of cancer, metastatic cancer. But on top of that, we have circulating tumor DNA via MSAT technology, right? So we're able to complement these guys here at the top. So with ctDNA, we're able to detect for the suspected, signal or signs of cancer through early detection. On top of that, we are able to see the response to treatment. For example, if one has cancer and they go through adjuvant therapy, chemotherapy, in order to treat for the cancer. So you want to see if that chemotherapy works or not. We can look at the ctDNA amount in the blood, right? Because if you have less ctDNA in the blood when one goes through, for example, chemotherapy, it means that you have a reducing number of cancer tumor cells in the body, which means that your chemotherapy is working, for example, right? So that's how ctDNA via MSAT technology or ctDNA is able to complement treatment response and then etc. as well. So they come hand in hand with imaging and the use of ctDNA technology for cancer screening, early cancer screening, and even later on if one is diagnosed with cancer. But the focus of today is effective cancer screening. So circulating tumor DNA can be released into the bloodstream, our blood, at any stage in tumor progression. Re-emphasizing the use of ctDNA in MSAT testing is to detect cancer at an early stage, and then later on, if one is diagnosed with cancer, to assess response to treatment, like the chemotherapy example that I mentioned, and then the outlook or prognosis or prediction of early recurrence as well. We're able to find that out as well. Okay, so with that, we end our first session. So we take it step by step, biteable pieces of information for today. And I shall stop here for a moment and open the floor for some questions from the audience. Please, yeah, sir.
I believe the article I read yesterday is MSAT. They found that the DNA of Hodgkin lymphoma in the blood is more than the DNA of the Hodgkin lymphoma in the tumor itself. So my question is currently this technology available in Malaysia?
This MSAT technology?
Yeah.
Yes, we do actually. So MSAT testing. So we, in Malaysia, from Gene Solutions, we have our spot mass MSAT testing technology, and it is available in Malaysia. Yeah.
So to do it, the hospital still need to send. It is not common in hospital. Instead of is in the center of MSAT.
Yeah, so in the case of Gene Solutions, we partner with healthcare providers, with secondary, tertiary hospitals, primary care, secondary care clinics as well, medical centers. And so these healthcare providers that we partner with, one can go in and walk in and request for the spot mass testing, which you would then be able to do through our healthcare providers that we've partnered with for this MSAT spot mass testing.
And with current technology, could it be possible to replace PET-CT scan for annual check?
Replace?
PET-CT scan, which has radiation,
Yeah.
possible cause another secondary cancer in the next 2 to 3 decades, and it replaces this which is no radiation.
So the idea of MSAT is we are not here to replace the standard of care, the gold standard of cancer screening. So the gold standard is still, as we speak today, your mammograms, your CT scan, even your PET-CT scan, your whole body CT scan, your MRIs, your colonoscopies. So MSAT, where it comes in, it comes in before that. Because let's say we take John Doe, particular John Doe person, right? So he's a supposedly healthy individual, and he does a regular medical checkup every year, and he opts to go for colonoscopy, CT scan for the lung, colonoscopy for the colon, MRI scan for the brain, for example. So this person can do that, which is fine, but on top of that, with MSAT, if you were to do an MSAT test, right? In this case, spot mass. If you have a detected circulating tumor DNA signal, let's say it is pointing to the tumor of origin suspected being in the colon. So this John Doe, he looks at his MSAT testing. He hasn't done his cancer screening yet, and then he sees that, okay, so I have a suspected ctDNA signal, which is pointing at my colon. So it will then help to narrow down when he goes for his regular medical checkup to go for a colonoscopy instead for that particular year. So this is where MSAT comes in. It helps to streamline and make the process of cancer screening, and especially early cancer screening, more efficient and effective and efficient for that individual. Yeah. So put simply, we are here to complement the gold standard of cancer screening. Yeah. Question? Yeah.
Because I see that you all talk about breast, lung, colorectal, liver, and stomach cancer.
Yes.
How about kidney?
Yes, kidney. Very good question. So for kidney, for MSAT, it's not a mainstream for kidney cancer. So for MSAT, it's mostly looking at the most common cancer types, right? And then for kidney, we have other means of looking at whether or not your kidney is functioning well. One would be a urine test. They look for your solute levels, looking at your any infections, when it comes to any white blood cells present in your urine, and they benchmark that against what a healthy urine would look like. And that would also give an indication of any potential, relation to cancer. So for kidney, for MSAT testing, as of now, the common cancer types that we are that MSAT testing is looking at are the ones that you mentioned as well. But there is, of course, further down the line for MSAT testing when there's an opportunity to include these other cancers as well to be part of MSAT testing.
But how are the cases in Malaysia for kidney?
Sorry?
Kidney cancer.
Yeah.
Because I see practically everyone talks about the others. They don't talk about kidney cancer anymore. So what is the case for kidney cancer in Malaysia?
The
Is there
case?
any studies for that?
The case, I don't have immediate information at the moment, but again, it relates to the most common cancer types in Malaysia. And in terms of the statistics and the exact number of cases per se, I would have to get back to you. But for now, for MSAT testing, it's mostly prevalent and prominent in the most common cancer types that were shared and being mentioned by you, ma'am. Yeah. No worries. Yeah.
Ahmad, he says that the prolonged taking of drugs, will affect our kidneys. So how can you do anything about that as a solution?
Right. So prolonged taking of drugs will affect your kidney.
Yeah.
So in this case, if one is primarily concerned about one's kidney, then on top of going for your regular medical checkups, you can also opt to go for MSAT as well, looking at other conditions that may be present. But looking at kidney per se, looking at just kidney, one can do for the regular medical checkup, and then one of the tests that they look at to see if the treatment is a bit harsh on your kidney is going for a urine test, right? Urine test. So a urine test will look at all the things that are in your urine, and then whether your urine is in good shape or not. Because our urine has a lot of things inside it. It has, it has waste. It has, some unused nutrients. It has, it may have bacteria. It may have, white blood cells. If in the case of cancer, usually when one has cancer, their immune system is in overdrive. They produce a lot of white blood cells to counter the cancer. So this can be detected in the kidney as well. But this is in relation to other cancer types. But when you're looking at cancer itself, you will still, a regular medical checkup, for example, to look at your urine content and benchmarking of how a healthy a kidney would look like in terms of the urine content would give a good indicator. And in the case of whether if you are on long-term medication to see if it has any effect on your kidney, and its availability, ability to flush out water, right? So we have, for example, a healthy kidney is able to recycle about 1 liter of water per hour. So again, that's another indicator that you can use if one is on long-term medication to see if there's any effect on your cancer. Yeah. But it works hand in hand. We have all these regular medical checkups. You have your MSAT testing. You have your cancer screening methods. They all come together for the purpose of improving the quality of life, and also for the topic of today, for effective early cancer screening as well. Yeah. Maybe 1 or 2 more questions before we move. Yeah. Hi.
I would like to find out if you're actually detecting cancer at stage 0 with cancer, what would be needed for cancer treatment? Cancer treatment looks like it's very effective.
Yeah. So for pre-cancerous staging or stage 0 cancer staging, right? So for MSAT technology, we are able to detect pre-cancerous, lesions. For example, if you take our colon, right? So we're able to detect for, they call it dysplasia, hyperplasia, which are conditions that may actually lead to cancer. We also have like precancerous polyps that we can also be able to detect. So in the case of precancerous lesions or polyps, once it is detected by MSAT testing, depending on where it is predicted to be found at, let's say it's the colon, then one would go for a colonoscopy, and then maybe a biopsy is taken to confirm if it's precancerous polyp or dysplasia, hyperplasia, and then what comes after would be whether you would need to go for treatment or not. So to put simply, MSET is able to detect for cancer, not just early cancer detection before the metastatic stage, but also precancerous staging and condition as well.
Yeah, thanks, Dr. Ahmad. Good morning. Actually, my name is Lim. I'm actually the colleague to Dr. Ahmad. I believe that actually the next slide is going to answer most of the questions that actually you highlight, especially when we are talking about the technology, for the early cancer screening. But before we go there, I think good that to answer your question that when it comes to the early cancer, whether it's a stage 0 or stage 1 or stage 2 and so on, typically the surgery will be the mistake. When it comes to cancer, if we can remove, you can throw it, it's the best. Then followed by whether you need to radio or you need to chemo or you need to have a targeted drug and so on, that will be a later. But I believe that that when it comes to this stage, definitely you have a specialist. Normally you say the surgeon, oncologist, all these people will get involved. So this is actually the common practice. Of course, when you go to specific cancer and so on, then maybe they have a different method of doing it. But surgery still will remain as a mainstay. Remove whatever tumor that is not belongs to your body. You need to remove it. Then if removable, curable rate is actually very high. I think this morning Dr. Murari mentioned about if you have a stage of 0 colorectal, cervical, if it can be removed, then basically actually you are quite safe for the next 10 years, 15 years. So this is actually the key. One more question that just now I think Madam you also asking about kidney cancer. To be frank, actually, I think kidney cancer maybe not fall under the top 10 of Malaysia, but it's important as well because it happened in the country, and it's not something that's easy to manage. But of course, when you're talking about the most common cancer, top 5, top 6, then you hear all about colorectal, breast, lung. These are the most important ones. So perhaps maybe we can find more information from statistics to address your question on maybe a number 9 or maybe number 11. I can't remember. So that's the key thing. But maybe let Dr. Ahmad go further, because there is actually the slide that you may create an interest in you, how we are using this multi-cancer early detection to detect the DNA in the bloodstream. Because we're talking about like colonoscopy and so on, it's more like when patient got symptoms, right? Stomach not feeling well for quite some time, you go and see doctor, then I think better we do something. But not to clean the bowel line, right? The one is quite extreme one. But like when the patient got symptoms, then maybe they go for mammogram, maybe they go for colonoscopy or CT scan and so on. What about if the cancer at early stage, when they don't produce symptoms, what are we going to do? Are we going to wait until they become the symptomatic at maybe the advanced or late stage? Then only do something. So this is the advance of the early cancer screening when there is no symptom, but you are high risk maybe. Then maybe there is a method for you, there is option for you to take the early action. This is actually the main objective of the multi-cancer early detection through the DNA. And also just now we mentioned about, I think Madam talked about the human, decision, right? When they're doing the ultrasound, right? It depends whether you're not happy today, then you cannot see anything, right? When it comes to this multi-cancer early detection technology that we are using, NGS, I'm not sure you heard about NGS or not, the next generation sequencing. I think you may have heard about mutation gene and so on, they detect the specific gene and then specific treatment, right? That is the NGS. We are using the NGS. And we are using the AI to actually do the calculation and also do the validation. There's no human looking into it and match and so on. It's all through the NGS platform, and we are using the AI to match. So these are the technology that actually we are using. So perhaps, Dr. Ahmad, you can share about the spot mask. Further, then maybe we can discuss further.
Yeah, thank you, CK.
Thank you.
And thank you. Yeah, sure.
Before you proceed, can I ask
Sorry, couldn't.
The cost.
What's involvement and does it cover all the diseases or just specifically to one type of cancer?
Yeah.
Can I
CK,
allow
Raja,
to
yeah.
And also another question is the monitoring test or you need to be prescribed or monitored by the
Thank you.
Thank you.
So first thing first is actually the cost is not cheap. Because this is really a new technology. And definitely when I think when we introduced a chrono or mammogram 20 years ago, it's almost the same. But until today, it's cheaper. At the moment, I think in the market it's about 3,000 plus for tests. Is that for one cancer? No. That's the reason why we say multi-cancer early detection. When you're doing colonoscopy, it's only for colon cancer. We are doing the mammogram, it's only for breast cancer. Am I right? So if I want to do 5 cancer, then I need to do a 5 test. You actually accumulate all the costs. How much? Maybe 8,000, 9,000, or 10,000. So when it comes to the MSAT spot mass, actually we are talking about is one test, simple blood draw. We are actually detecting 5 cancer types: breast, liver, lung, colorectal, stomach. 5 cancer. With only one test. Currently it's about 3,000 plus, if not mistaken. But today I think they are doing the new launch as well. The new launch promo at about maybe about 3,000. So this is actually the difference is one test for multiple cancer. I think just now also mentioned about the kidney cancer, whether it's in or not. At this moment, this technology is not yet include the kidney cancer because the one that we have, the validated one is only for 5. But in future, it can be added in or not. Yeah. Hopefully, I answered the question just now, the multi-organ and also the pricing. Description. Yes, actually, you need to go to the doctors because you need some. Doctor need to do some counseling for the patient. Okay, before and after the result, they need to actually inform them. Bear in mind that this test is not for everyone. It's only recommended for those patients with the cancer history. I mean the family member with the cancer history, because they belong to high risk, right? Those with the liver disease patient, it may actually end up with the liver cancer, right? These are also a high risk patient. Those heavy smoker, heavy drinker, and those, I think maybe you heard about the germline inherited cancer gene. Like, what's the name of it?
BRCA1, BRCA2.
Angelina Jolie,
right? You actually tested, got the BRCA gene, means that you